Hello, good afternoon all, and welcome to our EDI month. We've got an interesting webinar for you this morning. My name is Chinwe Benoit. I'm a consultant forensic psychiatrist with Derbyshire Healthcare Foundation Trust, and I'm also clinical director for the Forensic and Rehab Division and the president for Association of Black Psychiatrists. We've got a fantastic hour ahead of you today. We are discussing inequalities in staff in mental health services. Now, without much further ado, we'll just go straight into the webinar. Our first speaker will be Juliana Omumere, and she's part of the TIDES team. If you've not heard or looked up the TIDES study, please do. And she's from King's College London. Juliana, are you ready?
I'm ready. Thank you, Chinwe, and welcome everybody. Hope you're having a good day so far. So first slide, please. And I'll try and make sure this doesn't sound like I'm on a game show. So the focus of our talk today is about workplace inequalities. Actually, that's the wrong first slide, but if we can move to the second one. Thank you. So TIDES, as Chinwe was saying, TIDES is about tackling inequalities and discrimination experiences in health services, and fundamentally it's focused on trying to understand how discrimination that's both witnessed by healthcare professionals and also experienced is related to their work and health outcomes, and how that inequalities kind of feeds into services. And important to note that this is a programme of studies that is led by Professor Stephanie Hatch down at King's College. Next slide, please. So part of this work, really in terms of the early phase of this work, focused on reviewing over 900 participants, mainly from hospitals and services in the London area, very much to kind of focus on how they were experiencing their impacts of harassment and discrimination experiences in their places of work, which were health services. Next slide, please. And what the survey found in terms of the original research around TIDES were that those that identified as being women, those from Black minority ethnic groups, and those that also documented as being from migrant groups, these were the groups that we found that were particularly more likely to experience or indeed witness firsthand experiences of discrimination and harassment in the workplace. And much as what one would expect, but important to have that documented, is that that exposure to discrimination and harassment was particularly associated with poorer mental health outcomes and physical health outcomes. And as much as we'd probably understand if you've had that experience yourself, was very much related to lower job satisfaction and indeed longer periods of sickness absence. So really having quite an adverse experience both on you physically, mentally, but also actually in terms of the quality of the workplace. Next slide, please. So part of this work also involved interviewing a large sample of staff that was kind of a mixture of groups, people from nursing backgrounds, healthcare assistants at all different levels, and senior staff as part of this first phase. And it was really important because actually what they found there was that, you know, when people were exposed to these experiences around discrimination, and certainly people feeling quite unfairly disadvantaged in the workplace, their attributions and understanding as to why this was happening was often related to issues to do with race and ethnicity. Next slide, please. Other factors that's quite important in terms of people were exposed to also included things such as like unfair disciplinaries, having unfavourable or seemingly unfair work appraisals, and again people's explanations and understanding of that was very much linked to issues to do with race or ethnicity. The idea that this wouldn't have happened had I not been from this particular ethnic background or this particular racial group. Sadly, actually, many staff who were exposed to this and reporting these experiences often felt quite resigned to these types of discrimination and just felt like, you know, I was sort of brushing it off or carrying on. And what people tended to do was that people tend to either move on or indeed kind of step out of healthcare provision, healthcare services. And unfortunately, the same direction of travel happened, was that things often went unchallenged. So the situation stayed the same because actually the people that were most impacted would leave and left. Next slide, please. So work from Charlotte Woodhead and colleagues, also part of the TIDES team, wanted to do a bit more of a deeper dive into teams, into people's experiences around discrimination and exposure, and actually what actually works, what is actually happening on the ground. So next slide, please. So this was a qualitative study that involved interviews with a large group of people, particularly from nursing backgrounds, full-shape nurses and midwives, and again drawn from quite a diverse group of London trusts, and just prior to the start of the pandemic, and very much all at different levels of seniority. And in terms of broad sort of categorizations in terms of people's ethnic and racial background, and specifically done like that to kind of ensure anonymity. And what they asked people about was very much people's experiences again of having or witnessing or reporting or training around discrimination. As we know, it's not just being on the receiving end, but it's also observing it and seeing it happening to people, colleagues or otherwise, and also what you're able to do or feel able to do or feel empowered to do. So these were interviews and analysed through thematic analysis. Next slide, please. So the sort of main kind of findings from the qualitative work was that, reports of racism, discrimination and bullying, harassment behaviours, that kind of, real mix, independently or indeed in combination, tended to very much exploit racialised hierarchies and maintain them in many ways in teams. So where you had teams where there was lots of diversity, high diversity, but certainly a sense and a perception, experience of not very low inclusion, people not feeling included and being part of a team or a service, that tend to very much sort of shape those exclusion processes. And reports of racism were linked to a number of intersecting factors. So those could be things such as someone's migration status, perhaps you migrated here recently, or your language, or your religion. And all those, rather than being things to celebrate and to see as a good thing, these were things that were often, based on these interviews, seen as a tool for segregation and marginalisation within the workforce. And it's important again that you remember we are talking about staff here. We're talking about people that are in the position of trying to help service users and families and everybody else. And that, again, what came up from the interviews, that people tended to cope again through kind of, sticking to a group, an in-group perhaps, or moving teams, or perhaps most sadly, leaving the NHS. Next slide, please. So as part of the TIDES phase 2 work, which happened just after the pandemic, what we wanted to do was really consider how those ethnic inequalities that we're already seeing in NHS services, in healthcare workers, so to speak, how those inequalities were faring in the context of this national, global pandemic. Next slide, please. So what we did in terms of this involved really thinking about what are the key questions we wanted to ask our healthcare workers in the context of the pandemic. And that involved really trying to do that through consent, through co-production, so working with our stakeholder groups, working with our reference groups to really think about what were the key areas, what were the key topic areas, what were the key points that we needed to be thinking about when we're actually trying to engage with healthcare workers to see what their experiences were during COVID. And this involves, as I said, working with our stakeholder groups, doing anonymous surveys to really prioritise those key areas. Next slide, please. This slide just to really kind of see what the progression has been from TIDES 1. So when we think around TIDES 2, we developed an inequalities module, an inequality survey for a much broader study, the NHS Check study, where we wanted to focus on all of those healthcare workers in those different participating trusts, which is 18 of them, that were national, not just within London. and to also think about looking at sort of qualitative data, and we were able to compare it to how things were prior to the pandemic and indeed during and after, and to also look at some helpful resources to kind of address some of the issues that will come up. Next slide, please. So as part of the Inequalities survey that we took and completed as part of TIDES 2, we specifically wanted to look at experiences of discrimination in and outside of the workplace, mental and physical health, PPE availability, risk assessments and redeployment. Again, if I take your mind back to those were the really big issues that were around for staff at that time, and also attitudes to vaccination and support in the workplace. And this went alongside our broader investigations within the NHS Check study that looked at a variety of mental health issues as well. Next slide, please. So some sort of preliminary findings, this is work in progress now, but we know that certainly when we're thinking about nurses, and we looked at a broader group, but just for today, just focusing on nurses who reported coming from Black and other racially minoritised groups, reported a much higher incidence of experiencing bullying, harassment and discrimination from staff during the COVID period. And that's, again, we think obviously around the largest group our largest professional group within the NHS, that should be a concern for us all. Next slide, please. So as I said, work that we've done, that we focused on looking at around sort of vaccines and people's experience of and attitudes towards vaccine uptake. And what we found, again, as most people would have known, that definitely we looked at quite a broader group and mixed group in terms of their ethnicities and backgrounds. And whilst there was definitely similarities in terms of people's decision making as to whether to take up the vaccine as a healthcare professional, what we found was that for those from racially minoritised groups, that their decision making was also layered and indeed influenced by broader issues around institutional and structural discrimination. So concerns that staff had in terms of, how vaccines were developed, concerns that staff had in terms of just inequalities that they face and that they've been exposed to, and how that might impact on just even vaccine development, on who's told and who's expected to have vaccines, and how people felt, in terms of their own choices. And so it's very important for people to understand that whilst if I cast your mind back to a year ago, 18 months ago, when there was so much misinformation about, vaccine hesitancy, groups not taking it up, healthcare workers not taking it up, and actually missing the point that for many healthcare workers, and particularly those from marginalised groups, that their decision making was even further complicated by much more broader exposure to discrimination. Chinmay, you saying I've got 1 minute left? Okay, slides, please. Next one, please. Okay, so it's all very well for me to kind of talk about some of these issues that people have in teams. But a big part of the TIDES work is also thinking about helpful resources. Yes, we can know about discrimination, exposure and harassment, but actually what do we do about it? What can we do about it? So a big part of our work has been focused on developing useful and helpful resources for teams that can address issues around racial inequalities and impacts, but also to support training. Next slide, please. So a big part of that work, very briefly, is work that we've been doing on virtual reality. And this was very much set up from the feedback that we've had from participants that, yes, OK, you can tell us about discrimination exposure in our teams, but what do we do about it? I'm a manager, what can I do about it? I'm the person on the receiving end, what can I do about it? I can't keep telling people this is what's happening. So actually what we did was in co-development with staff groups, with individual staff, and following the sort of Delphi process, developed a virtual reality resource where it's described as walking in the shoes of which the goal is very much to remove the responsibility from those that have been harmed and those that have been discriminated against, but to support those in whatever way to understand what that's like, but also most importantly to help people in their development to do better and to change their behaviours, and actually to kind of make learning and development a much more exciting way to do something, particularly for something so emotionally challenging as racism and discrimination can be. Next slide, please. So we've using qualitative data, we used it to develop the VR profile, and these were different scenarios of real scenarios that can happen in our healthcare services where people are on the receiving end of discrimination or witnessing and observing that in others, and really wanted to capture what those nuances can be. And we've worked with researchers and script writers and actors and storytellers to bring that alive in a virtual reality platform. Literally, it's the last 2 slides, Chinmay. Next slide, please. So we developed the storyboards and recorded them, if you're familiar with them, as sort of 360 videos using actors, and then used the application to allow different viewers to experience the same scenario at the same time, and using that as a really helpful way to prompt those discussions, because we need to move beyond the discussion of just experiencing discrimination, but actually what can we do? What did you notice? How can we do things differently? So next slide, please. Some of our early phase feedback has been incredibly encouraging, as one would expect me to say that, but it definitely is. And I won't read them out to you, but people can read them themselves. But fundamentally, the idea is that it provides a safe place to actually look and experience those issues, but also to think about how to do things differently. And people talk about it being a fun and innovative way in terms of learning about these issues, but also about how to change their own attitudes and behaviour. We should be on to the last slide now. And just the training toolkits, just to talk about, you know, again, we can talk about race and racial inequalities in our teams, which Tides has really shown us. But what can we do about it? How do we measure that? How can we put things into place in terms of our processes and policies? And so we have used our race equality. We've developed a toolkit and used that again alongside our VR application. So not only can you kind of think about what to do differently, but you can also have a big influence on how to train your staff in your teams. Final slide. This just talks about how it was developed, and again, just for us in terms of working in Tides, it's a very iterative process that's working with our key stakeholders, and those key stakeholders are people in teams, they're workers, they're people from professional groups who help to kind of really bring alive what those key issues are. Final slide. So just really want to say special thanks to all the different groups of people that have taken part and supported and been part of the Tides programme. And, you know, you guys can read that afterwards as we run out of time. But it's definitely a group or collective effort. And the final slide. And if you do want to have more information and to come keep up to date with what's happening with the Tides, or certainly even to be involved with the VR resources and the toolkit, please do get in touch. Thank you.
Thank you, Juliana.
I'm sure that was the longest minute you've ever heard, haven't you, Chinmay?
Thank you, Juliana. Well, it was fantastic talk, actually, and giving lots of food for thought. I mean, it does link in quite well with the survey the Royal College did in 2021. Even the Association of Black Psychiatrists, we did a survey of Black psychiatrists in the workplace as well. And then we have the RES report, and, you know, the results that you keep getting, they chime. So I think you've put a challenge out there to employers and trusts. Now, I think we'll move speedily to the next talk. Please keep your questions coming. We will take the questions after the talk. Now we've got Jeremy Rose, who is the EDI manager, and Lucy Millard, who is the lead patient safety specialist and qualified OT, both from the North East London NHS Foundation Trust. So I'll let you introduce yourselves.
Well, good morning, good afternoon, everybody. It's a long day, but we're delighted to share our diversity and equality and inclusion. So next slide, please. Introducing myself, my name is Jeremy Rose. My pronouns are he, him, his, and I help run the EDI team. Lucy is going to be speaking about a particular issue that we have addressed. But next slide, please. We are really pleased and delighted to announce that we at NELFT have been working very hard to be disability confident, and therefore our award for the Disability Confident Leader Level 3 is a really important achievement for our trust. Our recognition of the hard work that all departments across NELFT, and NELFT is North East London Foundation Trust, and we have achieved this excellence, but it confirms, I personally think, the way that we're delivering the level of inclusion in our trust. And it's a reflection of the fact that we've been doing this for the last, well, since 2016. We started off as disability confident supporter, and it kind of goes through developer and leader and champion, but we are, as leader level 3, we are at the top of our disability support to staff. And it means that whether you are a patient, whether you are a team member, a supplier, and don't forget suppliers need to be on board with disability issues, or actually any of us within NELFT, means that we are disability confident and we have the experience in NELFT to promote disabilities. And not everybody talks about what disability they have, but it gives us extra confidence to continue and improve our service for staff and patients. And of course, with this learning and development, it means that we can aim higher. They're kind of like two examples that we've been doing. BSL training that we have opened up to all staff. We've run 2 cohorts at the moment. Around about 30 members of staff are doing the training, and that is at level 1. So you can imagine, I think it goes up to level 3. We've got a lot of learning to do, but within staff, you know, we have staff that have hearing disabilities, and patients that we spend a huge amount of translation out of our budget. And the idea is that we develop that service maybe in-house. And so therefore, when we say hello, as you can see on the slide, we mean it, and we understand the disability that some of our staff and patients have. Next slide, please. And part of this is developing the mental health passport, which Lucy will take you through. But I'm actually really pleased that on our hearing disability, member of staff is bringing a hearing dog, and actually the Havering Adult Community Learning team have just won an award for Intellectual Disability Award by the RC Psych Award. So Lucy, could you talk about your campaign?
Thanks very much, Jeremy. Hi everybody, my name's Lucy Millard, and I'm lead patient safety specialist. This mental health passport has just been launched, or is just in the process of being launched across NELFT this week, next week. And I'm just going to give you a really quick background as to really how this came about and what it's for. So this all started about 18 months ago. I was asked to chair the staff mental health network. So this is a monthly network for staff, about staff, and it was a place where staff could talk very candidly, and we could have very open conversations about mental health. And when we say mental health, it can be a very broad, very open subject to talk about. So what we do in the mental health network is actually introduce different topics, which has really kind of supported a more focused approach on mental illness, and that's kind of how it progressed. So we've talked about psychosis, personality disorders, bipolar, etc., various complex mental health conditions that staff are living with in the NHS. So then we came on to thinking about having a passport, so something that you can carry with you through the organisation when you move team, or you can take with you elsewhere to another service should you want to, that really supports a conversation between you and your manager or your supervisor about your own mental health. And as I said, that's a broad term. So the purpose of the mental health passport is to really support a conversation around the more complicated, the more detailed conversations that might not ever have otherwise come about. So it's the opportunity to open the door to talk about a mental illness that you might live with as a staff member, and to put out a plan, or to have a focus or a way of working within your team that supports you living with your mental illness. Now, this is really important. This does not replace your usual in-house, organisations, HR and EDI, other support processes that you might OccuHealth. Doesn't replace any of those supportive practices in place. It doesn't replace reasonable adjustments, but what it does, it can be the opening conversation to make it easier to explore those problems and what you're going to do. I've lived with mental illness myself for many years. I've also been a health professional. So initially there was always that question mark in my head, well, I can't do both. Surely a qualified occupational therapist can't also have her own mental illness. Who's going to want to work with me? But actually I now see it as it's enabled me to be as a brilliant occupational therapist, and a brilliant professional now in what I do. But it took a long time to get to that, because what we're doing with this passport is trying to remove that notion that you can't be both, and that actually you can be a health professional living with a mental illness, and actually you can function very well at work. In fact, work might be where you function the best, and your passport enables you to create a plan in order to do that. So that's really what it is. It's about 5 or 6 pages long, and you can include what you want, as little as you want or as much as you want. And as I've said, if it opens up the conversation to needing reasonable adjustments or additional specialist support somewhere, this is where you can jot down what you might need, and then your manager or you can follow the usual processes in your organisation to get that. So that's a very quick overview of where it came from. I don't know if there's any questions anyone's got for me on that. And if you need any help on knowing how to fill it out or where to even start with it, we're very happy to talk through that, because these conversations do not come easily to some people. So openly saying I have an anxiety disorder or I have obsessive compulsive disorder, 2 things I have, they don't come easily to some people to say that, and people might still think, oh, how can Lucy work under those conditions, living with that? But it actually enhanced my ability to do that, so to be a health professional. So it spoke to a lot of the qualities that I bring. So that's what it is. Anyone got any questions for me? I can't see the chat box.
Okay. No. Thank you. Thank you, Lucy. I mean, that is absolutely fantastic. And I'm hoping that it will also enable clinicians to be a bit more open about their mental health issues, because, you know, the stigma is even worse amongst clinicians. And like you said, help us start that conversation going. Well, we still have a few minutes. If there's anything you'd like to add.
I mean, what I would add to that is it's really important, because one of the things we've had to do with this passport in NELFT is support managers, because what we don't want to create is a place where managers then feel uncomfortable, because we don't expect people to be comfortable or be experts in talking about mental illness. That's not what we're creating. So as part of introducing this mental health passport, we are offering, we've done one of our network sessions was about supporting managers, what to do if someone is unwell, and it happened to me, what to do if one of your colleagues is unwell and maybe isn't able to see that, without them trying to counsel or get into territory that they're not comfortable with. So you do have to manage that and set the kind of scene, and I think some of that's going to come with a bit of actually people using it and saying, well, actually, right, my colleague has told me she's got personality disorder and she gets very affected by any sort of change or autism and gets affected by things. I'm not an expert, and now I'm really not quite sure what to do. So your managers or supervisors, whoever's on the other side of that conversation, just making sure that they know where to go to get that additional guidance, not to try and be the expert. You're not solving their problems, you're making sure that the environment, the work environment that your staff member walks into is as best equipped to deal with their presentation, their symptoms as possible. So I would say that's really important to do.
Okay, that's really helpful. I think I shall exercise my right as chair and ask you the first one. How long would this pilot, how long would the pilot take in NELFT, and your plans, or are there any plans to kind of maybe make it more general?
We haven't got any plan to make it more widespread. The pilot, I suppose we need to give it a few months, because I've had two people already ask me for a copy so that they can use it with their manager, and so I think a few months, maybe Jeremy and I need to discuss that and then decide what the next steps might be, depending on feedback, because we might well get some feedback about wording, or we need to provide more information on the back of the passport. So plans to come, I suppose, is my answer to that bit.
Okay. Well, it means you have to come back. You'll have to come back. So we'll have to host another one so we can hear what the results are. Now, it's very timely. Now to the Q&A. We've got a few questions already published. Should I hand over to you, Thea?
Yeah, thank you. I'll just read them out for you to answer. So Caroline has asked whether they can be sent a copy of the slides, please, as they'd like to be more involved. And then we've got another question from Johnny, who has said, RE, the VR training, did people have to respond to the incidents they saw as part of it? One of the difficult things can be freezing when you see or hear something offensive / abusive.
Yeah, and I think, you know, Johnny is spot on, but actually it's not dissimilar to what Lucy was saying. So that's why it's really encouraging to hear that. When you're in the moment, you know, whether it's a staff member talking to you or you're witnessing something, it's all very well, you know, what should be done in the book. It's in the moment. It's how you feel in the moment, and processes come into play. So within the VR, it's a really helpful place, because it is as it is, and you can control that. But actually what we can do, and which is what it's designed for, is to then prompt those discussions. So for the, you know, for the work that we've got different scenarios, and these were developed from, you know, real participants and what was extracted from the qualitative data as well. And they're different ones. They relate to things such as PPE, they relate to their practice in relation to like nursing mums or people just needing different work experiences. And you can be in the experience yourself, you can be the person observing that. But what is most important, or equally as important, is having those conversations. And so it is literally is because of that freezing or whatever it happens when we're often confronted with something that is not what we were expecting and is also very difficult. This is what it's designed to do, because as Lucy has said before, not everybody has the answers for everything. They just don't. And what happens is people end up feeling really bad afterwards, because it's all the recriminations of, I should have done this should have happened, I wish I'd have said that. And that's what can kind of perpetuate the situation and make it worse.
Okay. Any more questions?
There don't appear to be any more questions in the Q&A, but if anyone has any, please do post them in the Q&A chat box, and we'll answer them.
Okay.
Well, I have a question, if that's okay.
Okay, go on.
It was just a question for Lucy and Jeremy, actually, because it was so fascinating in terms of just hearing about the work. And I was just wondering, just particularly even Lucy, about the passport, about you know, where do you see this going?
It's a really good question. And the answer is I don't know. I suppose I've never done anything like this before. My role, this particular role, as I said, chairing the mental health network only started last June. So I don't know where I see it going. I'd like to think that in a staff survey next year or the year after, staff, we get a reflection that staff feel, oh, I can say that I've had a psychotic episode in the past, and no one is going to be horrified by it, and they can talk openly. Or someone might say, you know, I've had a personality disorder diagnosis when I was 17, and people aren't going to think, oh my goodness me, what are you doing here? You know, that actually they are more routine. So maybe in the future we have something that we can extract from the survey. I'm just thinking out loud here, really, Jeremy, about that. That using those kind of terminologies and not disguising everything under mental health because it's so big would be great. But like I said, we've got to be very careful. We're not expecting supervisor managers to be suddenly counselling people, resolving their problems. That is not what this is. It's just people being braver and then not being brave, because you shouldn't have to be brave, and that's kind of the point. But I do it. I sit at the front of the networks and talk very openly about my own mental illnesses and the diagnosis and all that sort of stuff. But I don't question it anymore. It's just made me the individual that I am.
I think that's the important thing, is the fact that culturally we take it as this is just the norm. This is something that we are open, and we offer a voice for your own disability. Hence why about a year and a half ago we launched the health passport, which has gone down really well, and we've made that interactive so it can be digitalized and online. We'll do the same for the mental health passport, so it will be active or interactive as well as a printed version. But the next steps actually is to do a menopause passport, because they are issues which face everyone, and we should be more open and honest about it, you know, and managers should take that on board in their flexibility and their working patterns within staff and even within patients. So it's a natural progression and something we're really proud of, that we treat as normal.
I think that's actually quite innovative, because as Lucy was speaking, I know we do a mental health, well, a health passport for patients, where so they don't keep repeating their stories. And honestly, why don't we do the same for staff? And you know, it's it sounds very sensible, but actually it isn't until you see it, and it's so novel as well. And actually brilliant for sort of opening up conversations, because that's what we want to do, is just open conversations. No, it's absolutely brilliant.
Yeah, I mean, and also it's signed off by your line manager, whoever it be. If you are head of department, it's signed off by your executive director. It means that it's unequivocal. It's there to help both the manager and yourself. So if there is something you can learn from this, both Lucy and I are very happy to talk about it. We're very happy to send you copies digitally and printed versions, and we're happy to share.
Yeah. Oh, if you're happy to share, that would be fantastic, if we may. All credit to you, of course, but we would it would be absolutely brilliant to see what comes out of other places.
There's a question that's come in the chat. I don't know if it's aimed at us or not. It's, what do you think about sharing personal information with service users? My training as an OT, we were always taught about professional boundaries from the outset, and I think I was very keen on keeping the more in-depth details about my own illnesses away from service users, because that is the professional boundary that I wanted to maintain. I think if you're empathizing with someone who's going through a very distressing experience, there's still boundaries. But we were having this conversation last week, and I know someone said that they'd had an experience where they reflected back to the service user that they had experienced something similar to what that service user had experienced, and I think the family members took umbrage to that, didn't like it. But in some instances, in the right moment, it might be you know, to empathise on a level and say you've had a similar experience. But I don't think sharing your illnesses, etc., is probably not something I would do.
I guess there's different things, isn't there? And I guess just being clear about the different conversations that we're having. So we go back to, and that's the reason I was fascinated in terms of where you guys could go with this as well. But in terms of the focus of my work, you know, and Lucy, you didn't even go into details about this, but often our automatic response is to think about, you know, staff as being, you know, this blank slate. And they don't come with any history, but also if indeed you have your own lived experience of mental health problems, which is not uncommon for anybody, but that's something outside my work. In terms of what we're talking about as well, is that staff, paid staff in trusts are finding that their mental health is adversely affected by what we do at work, by their discrimination and their exposure and harassment at work. A job that I'm paid to do, that I'm doing, you know, for whatever reason, and that's an issue. And so then when Jeremy talks about it, which is really important, you know, some of those people that are exposed to that discrimination, harassment and abuse will be from their line managers, will be from people in positions of power. So they're very unlikely to be those people that I'm going to be sharing my experiences with, because I don't know how you're going to use that or leverage that. And so rather than thinking, for me, and that's why I was fascinated about it, rather than seeing mental health as the thing over there, it happens, mental health problems happen to anyone. They can look like Lucy and they can look like me. It's what it is. But what's most damaging is that when that is from modifiable situations in our workplace. And so issues around, I found it fascinating with NELFT and the work that you're doing, because it just seems that you're really honing in on the culture about being inclusive. That's what this is about. But we need to be thinking about the mechanisms and the processes that are making it not inclusive. They're excluding groups and making groups poorly because they're at work.
That's fascinating insight, Julian. I'm mindful that there are other questions in the chat box and we have not got a lot of time. I mean, we could have this conversation all day, and absolute fascinating work. Thea, do you want to read out some of the other questions, please?
Yeah, sure. We've had a few more questions come in. Nina has asked, is there any research into the impact on minoritized staff or trust weaponizing referral to the regulator and the blatant racism of the GMC Aurora versus porn convicted white male doctor?
So who will be best placed to answer this? Are you aware of any, Juliana?
I'm not, I mean, you know, I'm not the word police, but I do know in terms of even just the word around the weaponising, the reality is if you are from certainly a racially minoritised member of staff, you're more likely to be subject to disciplinary action. You're more likely to lose, you're more likely to be monitored and have your work questioned and have your credentials and your skills questioned. You know, the question should be, you know, that we should be ensuring that people do take people to account. But actually, the evidence thus far is that, you know, you don't fare very well in those procedures. So the weaponisation is not a term that I would use at all. I think the question should be, why are certain groups, by virtue of just their race and their ethnicity, more likely to be subject to what is often unfounded and unfair disciplinary actions? And I can't speak to a specific case.
Thank you. I think there are more questions.
Yeah, so Kate has asked, please would you share the passports referred to, especially the interactive one? Many thanks.
Yeah, I'm very happy to do that. If you gather any of the names that would like a copy, I'll send a PDFs one out, and we can take it from there. And if you want sort of like a quick discussion, anybody, about how we put it together, as in why we've structured it the way that we have, contact Lucy and I. But I think for the mental health passport, best to chat to Lucy, because she's got the whole, what I would call the business case and the reasoning behind it, more than myself, who've come in kind of like halfway through.
Thank you. And I think there's an interesting one that's just coming from Nina.
Yes, so Nina has asked, as a female minoritized neurodiverse queer healthcare worker, pretty much every aspect of medicine is default as white cis ableist male. Without decolonization, how can this change?
Right, who's taking that one?
I'm happy just to kind of refer to a tiny bit, but I know in terms of efforts, certainly from, you know, very much led really by Jackie Dyer, was part of the Health Education England subgroups on mental health and inequalities, and really beginning to, which has all of the key, well, all of the professional groups represented, from social work to nursing, psychiatry, psychology, and allied therapists, to look at the curricula. And this is in relation to mental health. I can't speak for physical health colleagues, but to look at the actual curricula that our professional groups are being exposed to, and supporting a greater focus on recognising what those blind spots are, what are those truths that we've just taken as a given, but has ended up having one group as the default normed group. So I know that's happening in education, and I think that's really helpful. That's mental health education anyway.
I am mindful of time. Are there any more questions? I think we're banging time.
I think that's everything for questions now. Thank you, everyone.
We're banging time. I just want to say thank you so much. I mean, this just scratches the surface, and it's quite interesting that we continue to sort of to highlight this, because not only the impact on staff, but it has also profound impact on patients and patient care and the quality of the work done by staff. So on this note, I want to say thank you very much to Juliana, Lucy and Jeremy for very, very interesting and thought-provoking talk. Please go and look up the TIDE study, and I think Lucy, you'll find that quite a lot of people are interested in their mental health passport for for staff. So I'm sure you'd have a lot of requests, myself included. And I just want to say thank you to Thea and Clementine for enabling the smooth running of this webinar. So thank you all and have a very pleasant evening. Bye-bye.
Thank you, Chinwe. Great chairing. And Tia,
Thank you.
Jeremy and Lucy.